introduction of my beautiful friends here. Number one, we have osteoid osteoma, as you can see there. And then we have mahans and chondromas. And then we have giant cell tumor, also called osteoblastoma. Right now, remember? And then we have our osteochondroma. You can see that osteochondroma. And then we have our osteosarcoma. Okay, that's osteosarcoma. And then we have our D, that is Ewing sarcoma, D-duct, Ewing sarcoma. And then we have our multiple myeloma. Okay, we have our metastases, and then we have our chondrosarcoma. Okay, so let's go ahead and start with osteoid osteoma. So this is the commonest true benign tumor of bone. Okay, age, as I said in my previous video, first 2 decades of life. Okay, because it's not for the old ones. And then our Spider-Man here is a man, so it has male preponderance. Okay, and then sites, we said in the previous video, proximal femur. Okay, and then location, it's the diaphysis and metaphysis. Okay, and then clinical features, pain at night. You see, so this is my headphones. I had to buy it because I cannot sleep at night. I have to wake up and listen to music because there's severe pain at night, which is only is alleviated by NSAIDs. Yeah, if I take NSAIDs, I'll be okay. Okay, and then this, of course, tenderness, swelling. For any other tumor, if you don't remember a feature, just say those two. Swelling, tenderness, and most likely you'll be right. Okay, and then on radio, you see this circle. It will be round, oval, sharp needles, less than 2 centimeters. Okay, and then there'll be radiolucent, okay, and there will be sclerosis, okay, hyperreactive sclerosis around it. And when you do an MRI, there will be a large hyperintensity. Okay, management self-limiting. We give NSAIDs and review after every 6 months. Do surgery if the pain is so severe and you cannot bear anymore. Okay, and then here we have our giant cell tumor, also called osteoblastoma. You see what I'm doing? Ooh, sorry, that means it's so aggressive. It's brand new. It's so aggressive. And then our rhino here is a she, so this female preponderance. Okay, and then 5 is, always remember 5 is of giant cell tumor. It's in the elderly. Okay, old age, eccentric. Okay, expansive. It's expansive. It's in the epiphysis. Okay, and this eggshell cracking. Okay, you see our head here. This round thing. That's our eggshell cracking. Okay, and then it's found in the distal femur. Of course, we talked about that in my own series 1. Distal femur, that's around the knee, and then aggressive, as you have just seen. Okay, and then there'll be pain at the side, swelling, and pathological fractures. Those are the clinical features. And then soap bubble appearance. Yesterday I showed you, if you see a soap bubble appearance at the epiphysis, that is giant cell tumor or osteoblastoma. Okay, and then also honeycomb appearance as well. And then other features will be, of course, it's eccentric, lytic. Okay, at the epiphysis, and there'll be narrow. There'll be the cortex. There'll be narrow zone of transition. Okay, and then cortex. And then treatment, of course, because it's aggressive, always surgery. We gotta get rid of it. Okay, and if the cortex is intact, we shall do extended curettage and bone grafting. But if it is breached, we shall do excision and arthroplasty using tumor prosthesis. Okay, good. So our third friend here is called osteochondroma. Okay, as you can see. So osteochondromas, this is more of a developmental abnormality, but generally it is the most common benign tumor. Okay, and then it's formed by bone and cartilage, of course, from the name osteochondrome. Okay, and then exophytic lesion, as you can see, it grows away from the bone, so it's exophytic. It could be pedunculated, as you can see here. This is pedunculated, or it could be sessile. Sessile means it doesn't have this stalk. Okay, and then it also has a cartilaginous cap. Yeah, as you can see, cartilaginous cap, and it has its own growth plates and stops growing the moment bone stops growing. Okay, so when bone reaches maturity, this one also stops growing. Okay, and then of course, if I wanted someone to help me do something, I'll call a man. So this male preponderance, because I'll just call him to come and check my child if it is working. If it's not working, then it's bad news. So male preponderance. Okay, and then age, as I said in my first video, first 2 decades of life, because it's not in the inception syndrome. And then symptoms, it's always a painless, slow growing mass. In case patient comes with pain, it may be due to maybe bursitis, stalk fracture, okay, or malignancy or neurovascular compression. Okay, and then another feature, clinical feature, is joint movement restriction. Of course, it's going to restrict our joint. And then in radiology, of course, we shall see a well-defined exophytic growth at the metaphyseal area. Okay, and corticomedullary differentiation. Okay, there is no treatment. We just take it after 6 months. Yeah, and then extra peristalticization. If symptoms do not improve, we do extra. So our osteoS, aka snaky osteosarcoma. So this is the most common malignant tumor in children, okay, and most common malignancy of long bones, okay. And then of course our snaky is male, so it's more in males than females, and this bimodal. Snaky is two-faced, so bimodal age distribution. If first 2 decades of life, that's less than 20 years and more than 40 to 50 years, okay. And then site most commonly distal femur, okay. We talked about that, and location metaphysis of long bone, okay. And then pathologically, this mutation of RB and P53 gene, and it's associated with Life-Fumini syndrome, okay. And then classification, we have primary and secondary, okay. So primary and secondary. And rather primary, we have classical and non-classical. And then secondary, it could be due to osteomyelitis, radiation, that is ionizing, aneurysmal bone cysts, fibrous dysplasia, Paget's disease, elderly, it's mainly the elderly, and as poor prognosis, that is secondary. Okay, so let's go back to primary, that is classical. It's high grade, intramedullary, and this histological classification depending on the cells that is coming from or its forming. Okay, and then we have non-classical, which is not high grade. Okay, not intramedullary, and most commonly from the surface origin, so it could be periosteal or paraosteal. Okay, so clinical features of osteosarcoma: pain, of course. So here we're gonna have pain, we're gonna have swelling, as you can see here. There will be swelling, there will be base symptoms, of course, cancers, and it's high grade, so there's agents of metastasis, so there'll be symptoms, there'll be warmness, the skin will be shiny, stretchy, okay, and then it will be pulsatile, and joint movement will be restricted, okay, and then regional lymphadenopathy, of course, it's aggressive, and then we have neurovascular status will be compromised distally, where the cancer is, okay, and then the most common site of metastasis is to the lungs, so always remember to do chest examination, okay? And make sure there's no lung metastasis. And then radiologic features of our snaky here, as we remember. So in our first video, we said we have Codman's triangle, as you can see here, and the sun. Don't remember sun ray appearance, sun burst appearance here, okay? And then we shall also have, of course, the cortex of bone. Okay, bone generally will be destroyed, and there will be ill-defined margins. Okay, we can't really tell so much about our snaky. Treatments always chemotherapy combined with surgery. So new adjuvant chemotherapy, surgery, and adjuvant chemotherapy. So our guy here, this guy is chondrosarcoma, okay? It could be primary or secondary, okay? And then he's a guy, this male preference, more than 40 years. This guy is old, more than 40 years, okay? And then most common site is the metaphysis of femur, okay? So chondrosarcoma is always treated surgically, okay? There's no role of chemotherapy, and if we cannot resect it, we do radiotherapy, okay? And then our Ewing sarcoma, our D, okay? As you can see here. So our D comes from neuroectodermal cells, okay? This translocation of gene 1122, okay? Age young, of course, 0 to 20 years, okay? Most common sites, okay? It's a diaphysis of pelvis and femur, okay? And then our D for man, okay? So it's more common in men. And then our symptoms, they will be pain. You know, this horn is very painful to get put in my eyes. So there'll be pain, of course, swelling and systemic manifestations. And then on radiograph, what I'm going to say, onion peel appearance, okay, and calcification. Treatment of Ewing sarcoma, remember, chemo, surgery, chemo, okay, combination therapy. And then we have our multiple myeloma, yeah, okay, most commonly located at the axial skeleton, okay, that is the spine, the skull, okay, the pelvis, okay. It comes from the plasma cells and it's the most common primary bone tumor in adults, okay. It's curable. We do what? We do bone marrow transplants. We put a new bone marrow. Then this here is our metastasis, okay, which is the most common malignancy